Hello, everyone, and thank you for attending the GE Healthcare-sponsored SCCT webinar on Advanced Cardiac CT and Clinical Practices. My name is Amy Dubig, and I am the Global Product Manager of CT Clinical Applications here at GE Healthcare. And before we begin today's content, I would like to cover a few housekeeping items. For the best viewing experience, we recommend using a wired connection and closing any programs or browser sessions running in the background. Webinars are bandwidth intensive, so closing any unnecessary browsers or tabs will help conserve your bandwidth. For the best audio quality, please make sure your computer speakers or headsets are turned on and the volume is up. Also, make sure your media player and Adobe Flash Player are up to date. Some networks cause slides to advance more slowly than others. If your slides are behind, push F5 on your keyboard and it will refresh the page. If you have any questions during the webcast, you can submit them through the Q&A widget. We will try and answer as many questions as we can. If we do run out of time, please know we do capture all the questions and will follow up via email. This webinar will be recorded. An on-demand version of the webcast will be available approximately 1 week after the webcast. And now, moving on with the webinar, we are so very fortunate to have Dr. Amit Patel, who is the director of the cardiac imaging section within the Department of Radiology at University of Chicago. Dr. Amita Singh, who is an assistant professor of medicine within the cardiac imaging section of the Department of Cardiology at University of Chicago. Dr. Jeremy Slivnick, advanced cardiac imaging fellow at University of Chicago Medicine, and Dr. Michael Henry, advanced cardiac imaging fellow at University of Chicago Medicine, share their knowledge and expertise with us today. Dr. Henry, I'll turn it over to you.
Hello, everyone. Thank you for the opportunity to present this case. My name is Michael Henry. I am an advanced imaging cardiac fellow at the University of Chicago. And so we will start this with a case. This is a 76-year-old gentleman who has a history of hypertension on lisinopril, dyslipidemia on atorvastatin with a recent LDL of 69, and type 2 diabetes with a recent hemoglobin A1C of 7.3%. He had undergone elective coronary artery calcium scoring testing, which showed an elevated score of 419 that was primarily focused in the left anterior descending artery. This corresponded to a score of 59th percentile for age and gender matched cohort. He subsequently underwent an exercise ECG testing. This was his baseline ECG, which showed normal sinus rhythm without ST segment changes. At peak exercise, he was noted to have significant ST depressions in the infralateral leads. The summary of his exercise ECG stress test was that he went 7 minutes and 30 seconds on a Bruce protocol, corresponding to 9.3 METs. He achieved a target heart rate at 160 beats per minute and had a normal blood pressure response to exercise. The study was stopped due to generalized fatigue, and he did not experience any chest pain. As mentioned, he had 2.5 to 3 millimeters of ST depression focused in the infralateral leads. The patient was hesitant for an invasive strategy and was referred for coronary CTA to further define his coronary anatomy. Here are the results of his coronary CTA. As you can see, it was a technically adequate study with appropriate opacification of the left-sided heart structures. We'll focus on his coronary arteries. First of the right coronary artery is noted to have a normal origin. There is a focal bend in the ostial-to-proximal section of the vessel, and calcific plaque is noted in the proximal segment without significant stenosis. The vessel courses normally in the posterior AV groove and provides a posterolateral as well as a posterior descending artery branch in a dominant fashion. There is no severe obstructive stenosis in the right coronary artery. Now focusing on the left coronary system, the left main has a normal origin. There's a focus of calcium in the mid-left main without significant stenosis. It bifurcates into a left anterior descending and a left circumflex artery. The left anterior descending artery has a significant plaque that is primarily non-calcified in the proximal segment and appears to be associated with a significant stenosis greater than 70%. The vessel then continues in the anterior interventricular groove and courses to the apex. As we come back up, we'll focus on the branch vessels, and there's noted to be two significant diagonal branches supplying the lateral wall. In the proximal segment of both the first and second diagonal branch, there's significant plaque noted that is both non-calcified and calcified that appears to be suggestive of severe stenosis. The left circumflex artery is a large caliber vessel and gives rise to an obtuse marginal branch, as well as a posterolateral branch in which it terminates and supplies a significant portion of the infralateral wall. There appears to be some diffuse luminal irregularities as well as calcific plaque in the distal circumflex, terminating in the posterolateral branch. Focusing our attention back on that significant lesion in the LAD, we will perform a double oblique technique to look a little closer. And as we scroll from proximal to distal in the vessel, we can appreciate the significant stenosis with near loss of contrast opacification. There's also evidence in the vessel of a high-risk plaque feature, namely a napkin ring sign. And as we continue to scroll, we get appreciation for the length of the stenosis before the vessel reconstitutes. We also get an appreciation for the interaction with the first diagonal branch of this plaque, which, as we noted, itself was diseased. The data was sent to HeartFlow for CT-FFR analysis, which helped provide assessment of the hemodynamic sequelae of these plaques and was noted to have no flow-limiting disease in the RCA. In the left system, the CT-FFR value of the LAD following the significant proximal plaque was 0.73, suggesting hemodynamic significance. And this also corresponded to both the first and second diagonal branch with CT-FFR values of 0.62 and 0.52 respectively. The distal left circumflex into the posterolateral branch was also noted to be flow limiting at 0.61. The patient then underwent invasive angiography, which confirmed the findings of the coronary CTA with a significant proximal stenosis in the LAD, as well as distal disease in the left circumflex. The diagonal branch disease of both the first and second diagonal branch is also appreciated on the invasive angiogram. The patient, after multidisciplinary discussion, was ultimately referred for coronary artery bypass graft surgery, which went successfully, and the patient is doing quite well now. Thank you for your time.
Good afternoon. I'm Amit Patel. I'm an associate professor of medicine and radiology at University of Chicago, where I'm the director of cardiac MRI, CT, and PET. I'm going to be talking to you about the assessment of coronary disease, anatomy, and physiology today. For the last 20 years or so, we've been really using the burden of ischemia to help us determine whether a patient would benefit from revascularization or medical therapy. We have long believed that for those patients who have more than 10% myocardial ischemia are likely to do better with revascularization than with just medical therapy alone. However, based on the ischemia trial, this theory has been more or less debunked recently. Here, a randomized controlled trial comparing patients with moderate or severe amount of ischemia were randomized to either an invasive strategy with revascularization plus medical therapy or just aggressive medical therapy alone. And as you can see on these four graphs, that there's no difference in patient outcomes regardless of which arm they were randomized to. Now, cardiac CT has been around for nearly 20 years and has been extensively studied and validated. Here are just three of the larger initial multi-center studies validating the diagnostic performance of cardiac CT. As you can see, the negative predictive value is excellent, as is the overall diagnostic performance when compared against invasive coronary angiography. There have been several randomized controlled trials studying the role of cardiac CT, and the first two here, ROMICAT and ACRIN, are trials focused on patients presenting with chest pain to the emergency room, and both studies show more efficient throughput of patients randomized to the CT arm when compared to standard of care, reductions in the amount or length of hospital stay, and additionally, all of this occurs without an increase in adverse cardiac events. In the CAP and CRESCENT trials, patients were randomized to cardiac CT or treadmill stress testing. And I think the general idea is that patients in the CT arm had reduced downstream testing, and patients in the CT arm had a improvement in their symptomatology and improved cardiac events. The PROMISE trial is over 10,000 patients, and here patients were randomized to stress testing, typically with imaging versus cardiac CT. And in this trial, there was no significant difference in patient outcomes or costs. However, the cardiac event rate was noted to be fairly low in the PROMISE trial. In the SCART Heart trial, so another trial with over 4,000 patients, here randomized to standard of care coronary CT. And you can see, regardless of which arm patient was randomized to, the rate of coronary angiography was the same, as was the rate of revascularization. However, those patients randomized to coronary CTA had a lower rate of myocardial infarction relative to those patients randomized to the standard of care arm. This difference is believed to be driven by the increased use of medical therapy in the coronary CTA arm due to the detection of non-obstructive plaques that would not be detected by a stress test. Here in post-hoc analysis from the ischemia trial, we really identified some interesting new findings, particularly in those patients who had moderate or severe ischemia. They did not appear to have a higher event rate compared to those patients who had no or mild ischemia. And similarly, they did not appear to have a higher rate of myocardial infarction either. However, when the data was looked at from the perspective of the coronary anatomy they had, those patients who had severe 3-vessel coronary disease or severe 2-vessel coronary disease with one of the stenoses, including a proximal LAD lesion, you could see that that group of patients had an increased rate of all-cause mortality and also an increased rate of myocardial infarction, together suggesting that the anatomy is driving patient outcomes rather than the burden of ischemia. Now, kind of post-hoc analysis from the ischemia trial also provided some interesting new insights into the impact of ischemic burden on prediction of risk. And we can see relative to the patients who had no or mild ischemia, those patients with moderate or severe ischemia did not have a difference in their mortality, nor did they have a higher rate of myocardial infarction that could be definitively detected. However, when they looked at the anatomy of these patients, those patients who had severe 3-vessel coronary disease or severe 2-vessel coronary disease in which one of the lesions was a proximal LAD stenosis, you can see those patients indeed had a higher rate of all-cause mortality, and a higher rate of myocardial infarction, suggesting that the anatomy is more predictive of outcomes than the ischemia. And one of the advantages of coronary CT is the ability to actually detect non-obstructive plaques and also to detect plaque morphology. So here you can see a proximal LAD stenosis, and you can appreciate there's a low attenuation along the endothelial boundary and then a rim of higher attenuation seen here in the long axis. On cross-section, you can see normal lumen of the LAD here, which narrows considerably. There's a large plaque sitting on top of the stenosis, and you can see the area of low attenuation and then increased attenuation along the periphery. This pattern is what's commonly described as the napkin ring sign and is considered to be a feature of the vulnerable plaque. Other features include positive remodeling, presence of low attenuation, and spotty calcification. Now, here's a sub-analysis from the Scott-Hart trial where they looked at whether the burden of low attenuation non-calcified plaque predicted the future occurrence of fatal and non-fatal MI. And sure enough, those patients who had more than 4% low attenuation plaque burden had worse outcomes than those patients who had less than 4% low attenuation plaque burden. And here's just an example of a patient who has 3-vessel coronary disease. Here in the LAD, we can zoom in and look at the plaque characterization. Here's the region that's boxed in, and you can see there's a large low attenuation plaque painted orange here. And sure enough, when the patient presented later on, they had a myocardial infarction with an obstruction right at the level of this low attenuation plaque. Now, we also know that revascularization guided by the presence of a hemodynamically significant stenosis as determined by invasive FFR is superior to revascularization guided by coronary anatomy alone. This is just trial from the FAME studies showing improved survival when treatment was based on the presence of hemodynamically significant stenoses. I don't have to explain to this audience that with coronary CT, it is now possible to calculate throughout the coronary tree the CT FFR values non-invasively from the images that were already acquired. So here you can see coronary CT in the proximal LAD. You see what appears to be a significant stenosis. And sure enough, on the CT FFR, you can see a sudden drop in the CT FFR value just distal to the significant stenosis. The FFR value by CT was measured to be 0.62. And then on invasive coronary angiography, you can confirm the stenosis and also that the FFR value is 0.65. Interestingly, here in this other patient in the RCA, there appears to be a similarly severe stenosis. However, on the CT-FFR images, you can see that distal to that stenosis, the CT-FFR value is normal. And sure enough, during coronary angiography, the stenosis is identified and the invasive FFR value is also normal. Multiple studies have looked at the diagnostic performance of CT-FFR and have shown that on both a per vessel and per patient basis, the diagnostic performance of CT-FFR is excellent. Here's an interesting study in which patients were referred to both to coronary CT and CT-FFR, also for stress PET and stress PET. SPECT, I should say, and all patients also underwent an invasive coronary angiogram with fractional flow reserve calculation. And what you can see is that SPECT had the poorest performance for detecting hemodynamically significant stenosis. PET performed better than SPECT, and here CT-FFR plus coronary CT outperform both stress PET and stress SPECT for the detection of hemodynamically significant coronary disease. Now, this is data that's recently published from the Forecast study, where 1,400 patients from, I believe, 11 different centers in Europe were randomized to either standard of care or the experimental arm. In the experimental arm, FFRCT was utilized in patients who had intermediate or worse degrees of coronary stenosis on the CT. And what they found was that there was no difference in cost between the experimental arm and the standard of care arm. There's no difference in symptom frequency. There's no difference in quality of life. There's no difference in major adverse cardiac events. However, there was a significant reduction in the number of patients who ultimately needed invasive coronary angiography, which is a benefit for the patient, of course. Now, another way to determine the presence of a hemodynamically significant stenosis is through the use of vasodilator CT myocardial perfusion imaging. Here on the left is a normal patient with normal perfusion at rest and at stress. On the right is a patient with obstructed LAD, which has been collateralized from the right coronary artery. On the resting perfusion, you see a malperfusion defect in the LAD, which is significantly exacerbated and worsened during stress. And on the color bullseye plot, you can see that the amount of ischemia increases considerably with stress over rest. Now, here's a meta-analysis comparing all of the different non-invasive stress testing techniques that are now available against the reference standard of invasive FFR. And what you can see is that stress CT perfusion performs as well as stress MRI and stress PET. And all three of these more newer techniques are outperforming stress echo and stress SPECT. Now, this is an interesting study published a couple of years ago in JACC Imaging, where patients were randomized to just a coronary CTA alone arm versus a coronary CTA with CT perfusion being utilized in those patients who had more than a 50% stenosis. And what happened is that in those patients who had between a quarter and a third of patients who had of the patients in the study had coronary stenosis greater than 50%. When these patients underwent stress testing, roughly half of them had concordant perfusion defect or ischemia in the territory distal to the stenosis, and half did not. And what this translated into is that in the coronary CTA arm, approximately 100 patients ultimately ended up getting an invasive coronary angiogram, and 57% of them were found to have a hemodynamically significant cath. On the other hand, in those patients in the CT perfusion arm, only 28% made it to the cath lab, and 82% of those patients who made it to the cath lab had hemodynamically significant coronary disease. And so this really highlights how we can reduce the number of patients needing an invasive coronary angiogram. Now, there is a significant number of studies looking at the prognostic value of CT perfusion. Here in this study, looking at the added value of stress CT perfusion in patients with stents, heavy calcification, and obstructive coronary disease. These are all the most challenging cases with coronary CT, and you can see the presence of ischemia consistently was associated with worse outcomes relative to those who had no ischemia. So how do we put all of this together? Well, first is a study by Dr. Pontone and colleagues showing that use of CT stress perfusion and CT FFR are both associated with better diagnostic performance when compared against just coronary CTA. However, when you use a staggered approach which combines all the modalities, diagnostic performance is the best of all. And so I think where we're going in the future is that patients who have suspected coronary disease will first undergo coronary CTA. If there's more than a moderate or greater degree of stenosis, then patients will have their images submitted for a CT-FFR analysis. If the CT-FFR analysis is in the gray zone, then they'll get stress CT perfusion. And only those patients ultimately determined to have, non-invasively determined to have hemodynamically significant coronary stenosis will undergo invasive coronary angiography and revascularization. And with that, I'd like to thank all the fellows who've supported our lab and the research we do, and be happy to take any questions at the end of this seminar. Thanks for listening.
Hi, my name is Jeremy Slivnick, and I'm an advanced cardiac imaging fellow at the University of Chicago. And I want to thank the SCCT and GE for allowing me to present today. We're going to talk about functional assessment using cardiac CTA. So I have nothing to disclose. We'll start off with a case presentation. So we have a 95-year-old lady who had a previous history of multivessel CABG done in 2005, 6 years prior, and then subsequently underwent Tavr implantation 2 years later with a 26-millimeter sapien heart valve, and post-operatively required a pacemaker due to bradycardia after a Tavr procedure. So she's seen in clinic, and this is just basically to provide a background of pre-Tavr imaging, where we can see a severely stenotic trileaflet aortic valve. And we can see pre-Tavr, she had gradients consistent with severe aortic stenosis with a mean gradient of 43 that subsequently decreased to 12 millimeters of mercury following her Tavr implantation, which is an acceptable result with the sapien heart valve. So at the time of her clinic visit, she has technically difficult windows on her post-Tavr echo. And on Doppler assessment, the mean gradient had increased to 31 millimeters of mercury from that previously normal value of 12 millimeters following her Tavr implantation. For that reason, a cardiac CTA was ordered in order to further assess for the etiology of her abnormal gradient seen on echo. So one of the capabilities we have with cardiac CT is the ability to do we typically at University of Chicago acquire a full phase acquisition with dose modulation, which allows us to get a good assessment of left and right ventricular function. So here we can see she has fairly preserved left ventricular systolic function. EF was around 65%, fairly preserved right ventricular function as well. We don't see any wall motion abnormalities so far. Here's the two-chamber view. And again, when we kind of slide down here in the short axis, again, we're not seeing any wall motion abnormalities, any evidence of intracardiac thrombi. So turning our attention now to the prosthesis, we can now get a better look at the Tavr valve. So here in the short axis view, we can already start to appreciate that there's evidence of leaflet thickening on predominantly the right coronary cusp and the non-coronary cusp. And when we look in the short axis view, again, we can see this thickening on the non-coronary cusp here shown on the left side. So if we slow it down and go to our phase, end diastolic phase, we can really start to appreciate this thickening seen on the non-coronary cusp, which is consistent with hypoattenuated leaflet thickening or HALT, which occurs due to subclinical buildup of thrombus on the valve leaflets following Tavr, which has been fairly well described following this procedure, and is a reasonable cause for gradient elevation. If we go back down to the valve and pan around, we can pan to the right coronary cusp, where we again can see the thickening on that leaflet as well, which is shown on the top here. Also consistent with HALT involving that leaflet. And we can play the cine imaging in the short axis. Which shows decreased excursion, particularly involving those two leaflets. Which is the likely explanation for the gradient elevation of this patient. So to update our care, the patient was started on Eliquis for anticoagulation due to the findings seen on cardiac CTA. And on follow-up echo, the gradient was noted to have returned back down to 12 millimeters of mercury, which was consistent with her post-Tavr values, which was significant improvement, also supporting the successful treatment of HALT in this patient.
Hi, my name is Amita Singh. I'm a cardiac imager at the University of Chicago, and it's my pleasure to be participating in today's webinar and spend time speaking on the topic of dynamic cardiac CT in the assessment of cardiac function in valvular disease. We've long known the value of cardiac CT in the assessment of coronary disease and structural heart disease pre-planning, but another powerful application associated with this modality is the ability to acquire dynamic 3D data sets over time, referred to by some as 4D CT, with the additional temporal component enabling the evaluation of cardiac function, wall motion, and valvular assessment. These are all almost always relevant to clinical care. Additional momentum is growing in the application of dynamic CT in prosthetic valve assessment, suspected or known endocarditis, and evaluation of LVAD patients, which all represent special populations in which CT can be useful as part of a multimodality algorithm. Before we discuss the specifics, I think it's worthwhile to review why perform functional CT at all. There are clear advantages, the first being that it harnesses the excellent spatial resolution, high temporal resolution, good myocardial blood pool contrast, and multiplanar reconstructive capability that we know and love about CT. CT can be rapidly acquired with scanners available widely and less operator dependence with the correct protocols in place. Additionally, beta blocker premedication is not strictly necessary, though it may be helpful in certain applications that we'll discuss in a bit. Lastly, functional CT can provide complementary data coupled with evaluation of coronary arteries and cardiac structure. In short, it can easily be integrated to create a comprehensive CT exam. Important limitations include the attendant increase in radiation exposure with dynamic imaging, the intrinsic need for iodinated contrast, sometimes more than the typical arterial phase study alone, which may present challenges for patients with CKD or contrast allergies. And lastly, the difficulty of overcoming image quality abnormalities that may exist in the setting of a large body habitus, arrhythmia or motion, and cardiac device-related artifacts. Fortunately, the current era of modern CT scanners are helping put forth a new and improved approach to dynamic CT imaging. Wide coverage and dual source scanners permit single heartbeat, full coverage scanning. Faster gantry rotation times have greatly improved temporal resolution of cardiac scans. Multi-phase imaging can be performed using either a retrospective ECG gating protocol or with prospective ECG triggered imaging with padding to widen the acquisition window and capture an entire cardiac cycle. Dose modulation and iterative reconstructions can also help to reduce total radiation exposure to the patient, but preserve diagnostic quality imaging for interpretation. The assessment of biventricular function is almost always a relevant piece of clinical data and can be accurately gleaned from dynamic CT. Benefits of CT in this realm include the lack of geometric assumptions associated with the modality and the availability of existing software which can help with expedient volumetric analysis. As previously mentioned, beta blockers are not strictly required for the evaluation of cardiac function. If the left ventricle is the chamber of interest, a standard arterial phase injection bolus and flow rate will generally yield adequate LV opacification for analysis. Post-processing, which we'll briefly discuss next, can also evaluate LV mass, though this step can be more labor-intensive. Reassuringly, there's already a wide body of data which demonstrates good correlation between CT-derived LV ejection fraction compared to cardiac MRI across a spectrum of pathology, including patients with coronary disease, patients who have undergone heart transplant, valve disease, and patients with cardiomyopathy. With appropriate planning, RV systolic function can also be evaluated for, but generally requires dedicated efforts to adequately opacify the chamber. This generally can be done using a triphasic injection, and when adequate opacification can be achieved with the right ventricle, studies have shown that it can approximate with good correlation cardiac MRI-based RV ejection fraction estimates. This can have specific utility in the evaluation of patients with suspected ARVC, congenital disease and valvulopathy, or even in cases where echo is unable to visualize RV function. For functional analysis, a multi-phase reformatted dataset of maximally 1.5 millimeter thickness images without overlap should be reconstructed at either 10% increments or 10 phases for single source CT scanners or 5% increments or 20 phases for dual source CT scanners through the cardiac cycle from the onset of the R wave for assessment of global LV function in a cine mode as shown here. Images should be viewed in 2D cine loops with manipulation of planes up to the operator, but ideally starting using the short axis 2-chamber and 4-chamber planes as shown here. Quantitative methods for EF assessment vary, but generally fall under 3 categories with relevant details as follows. So the first is manual contours, which generally include the papillary muscles in the blood pool and thus are associated with slightly larger volumes but similar EF values compared to other methods. The major caveat to this is it can be rather time-consuming and associated with significant inter-observer variability. Next are semi-automated methods in which the contours are auto-detected, but there is still a need for adjustment of the mitral valve plane, confirmation of end diastolic and systolic phases. But when this approach is used, it generally demonstrates lower inter-observer variability than when compared to the manual approach. Lastly, and perhaps the most streamlined for clinical use, is automated threshold segmentation, which is an automatic technique that relies upon differences in attenuation between the blood pool and the myocardium, and thus is able to exclude the papillary muscles from the blood pool. Accordingly, the volumes with this method are lower due to the papillary muscle exclusion, but this approach has good reproducibility. Depending on scan quality, this method may be easier to apply in practice for the LV than when compared to the RV. All of these approaches can be used to generate not just an ejection fraction, but also a time volume curve as shown at the right here. But the accuracy of this curve can be compromised by things like suboptimal opacification, devices or motion, and cardiac shunting. Interpretation of systolic function incorporates the typical qualitative categories that we're familiar with from other modalities, with CT demonstrating reasonable inter-observer variability overall reported in studies up to 11% for volumes and 2 to 8% for ejection fraction. Assessment of regional wall motion abnormalities can also be done using the AHA 17 segment convention, but abnormalities should be confirmed in 2 separate imaging planes to be considered positive. Additional parameters of regional indices can be used as representative of wall thickening, with normal wall thickening generally being 5 millimeters or more in systole. An additional assessment of perfusion abnormalities manifest as subendocardial or transmural hypoattenuation that persists in multiple phases can be used as a surrogate of resting perfusion abnormalities and signify the presence of ischemia. Previous work has shown that resting perfusion defects, when present, improve the sensitivity of coronary CTA for significant stenosis and add incremental value to the exam. Fortunately, we work in the era of CTFFR, but as shown here in the case of a patient with a left circ stent, anterolateral and infralateral hypokinesis, reduced wall thickening, and perfusion defects, these findings can still be high yield and facilitated by the use of dynamic CT methods. Extending beyond the role of pre-structural heart interventions and kind of entering into the valvular space, dynamic CT has a lot to offer, particularly in the assessment of mitral valve disease. This is again due to the ability of CT to provide 3D visualization of the components of the mitral valve and its apparatus, which are further evaluable with multiplanar reconstruction to localize pathology, using a similar convention to echocardiography with a representative short axis cine image shown at upper right here. This is a frequent indication for cardiac CT at our own institution. Mitral valve prolapse in particular can be reliably assessed by CT with excellent sensitivity and specificity when compared to echo, with additional data supporting surgical correlation of CT findings. It can also serve to identify more malignant forms of the disease like mitral annular disjunction, or be utilized to determine regurgitant orifice area and annular dimensions in the preoperative setting. For mitral stenosis, the annular calcification burden can be adequately visualized and quantified with relevant implications, we know, in the setting of transcatheter interventional planning. But it's important to note that mitral valve area planimetry, while it can be performed with CT, tends to yield larger values than echo-based planimetered area. So CT data should be used really in conjunction, integrated with echo data in cases of mitral stenosis. The aortic valve is also very well visualized by CT, and while diastolic phases can be sufficient to identify morphology, in most cases it's often enhanced or more easily confirmed using dynamic imaging. CT again has excellent sensitivity and specificity for identification of bicuspid aortic valves, which can sometimes be difficult to visualize by echocardiogram, either due to image quality or obscuring by calcium in patients with aortic stenosis. And CT can also identify rare congenital variations, such as the quadricuspid aortic valve shown here. An additional advantage of CT includes its ability to concurrently evaluate for the presence of aortopathy, which often has important implications in the bicuspid patient population. Multi-detector CT planimetry for the aortic valve has a good correlation with both transthoracic and TEE, and can be used as an alternative modality in cases where echo imaging is limited. The integration of multi-detector CT as an adjunctive modality in the evaluation of prosthetic valve dysfunction is increasingly being recognized. Valve dysfunction is a common clinical scenario, typically characterized by abnormal gradients across a surgical or transcatheter replaced valve with or without symptoms. Advantages of CT include the ability to directly visualize leaflet excursion, detect evidence of valve degeneration, differentiate thrombus from pannus, and detect endocarditis and its complications, which with particular value, in prosthetic valve obstruction cases when echo may be suboptimal or inconclusive. However, when using CT for this clinical purpose, there are important imaging considerations to review. The primary one is that beam hardening from metallic components of the valve can occur, and while they may be ameliorated by things like higher KVP, sometimes the use of beta blocker pre-medication, something, as I've said, is not typically critical for functional CT imaging, can help in this regard. Another consideration is that the usual strategy of dose modulation can actually compromise image quality, and so most protocols for this purpose will come with an attendant increase in radiation dose to the patient, which should always be weighed in individual cases. The value of CT in prosthetic valve obstruction really lies in its ability to directly visualize leaflet excursion and in the differentiation of thrombus from pannus. As in the case of elevated gradients, true stenosis will typically demonstrate abnormal or restricted leaflet motion, but patient prosthesis mismatch will have presumably normal leaflet motion instead. This can be difficult to see by echocardiography, particularly with acoustic shadowing and other common artifacts that can obscure leaflet delineation. Another clear advantage with CT is the evaluation of associated hypodense lesions adjacent to or involving the valve, with typical Hounsfield units of thrombus about less than 90 and typical Hounsfield units of pannus greater than 145. A recent meta-analysis in JACC comparing CT and the evaluation of prosthetic valve obstruction showed that both 3D TEE and CT are the most sensitive modalities for the detection of obstruction in this population, but CT appeared to be a better differentiator of pannus from thrombus for the reasons that I just reviewed. Another interesting, if somewhat controversial application of CT imaging is in the post-Tavr and Tavr space. In the detection of symptomatic hemodynamically significant thrombosis is fortunately clinically rare. Subclinical thrombosis can be seen and presents with a wide range of symptoms ranging from asymptomatic elevated gradients most commonly to heart failure and embolic events less often. The literature actually reports quite a vast spectrum of incidence for this, anywhere between 5 to 13% in registry and trial data for both valve types. The clinical implications of this entity remain somewhat controversial, with most studies indicating that incidental subclinical leaflet thrombosis is not associated with greater mortality or stroke risk, but the observation that rates of this are far lower in patients who are on systemic anticoagulation when compared to their counterparts on antiplatelet therapy alone. Regardless, recognition of this is greatly aided by cardiac CT, with two specific terminologies used to describe abnormalities. The first being HALT, or hypoattenuated leaflet thickening, which appears as a meniscal defect in the base to periphery of the leaflet with variable degrees of involvement. Ham or hypoattenuation affecting motion can be present or absent with halt, with reduction in leaflet motion of greater than 50% deemed significant. These findings can be dynamic, as shown in the graphic here, and improve with anticoagulation treatment. But diagnosis and longitudinal follow-up are both really feasible using CT and have helped us to understand what can be sometimes an occult phenomenon in post-valve patients, though debate regarding optimal prevention strategies for it does persist. I want to emphasize that CT can be useful for surgical and transcatheter valve assessment. Shown here is a case of a 55-year-old man from our institution with a history of a bioprosthetic mitral valve placed 2 years prior, who presented with an increase in transmitral gradients and stroke. TEE shown here demonstrated a quote unquote stuck leaflet with echogenic material impinging opening of one of the cusps, concerning for thrombus versus vegetation. CT was acquired and demonstrated with nice correlation, hypodense material with the Hounsfield unit of less than 90 layered in the immobile cusp shown here, most consistent with thrombus. The patient was anticoagulated with improvement in his gradients and discharged home after 1 week. Another valvular disease well served by the use of dynamic CT is endocarditis, as CT permits evaluation of both valvular and perivalvular lesions in patients who either have known or suspected endocarditis. And CT can additionally be sometimes used for a non-invasive coronary evaluation at the same time in patients who may require cardiac surgery. CT can be harnessed in both native and prosthetic valve endocarditis, but again, specific considerations should be taken in the protocol for image acquisition in these patients. A triphasic contrast injection and triphasic retrospective scan may be optimal, as it will allow for opacification of both the right and left heart to better visualize all valves, and non-contrast and delayed phase imaging may help in the determination of abnormal fistulous tracts or perivalvular complications. A recent report from a center applying this protocol in a cohort of patients with endocarditis reported a mean radiation dose of 8.3 millisieverts with this approach, which again warrants careful consideration in the care of individual patients, but can often help in definitive management of this otherwise morbid condition. 5 to 10% phase increment reconstructions are ideal, again, to optimize detection of not just vegetations, but pseudoaneurysm, abscess, and fistula. The role of CT in the multimodality evaluation of endocarditis is now formally recognized by cardiology societies, with the European guidelines acknowledging CT-based findings of endocarditis as a major criteria for diagnosis, and the 2014 ACC valve guidelines stating a class 2A indication for CT in the setting of valvular or paravalvular infections when echo imaging is suboptimal. We fortunately have recent data to support the use of CT in this practice, with recent meta-analyses pointing to the likely benefit of a combined TEE and cardiac CT approach, with TE superior in the detection of leaflet abnormalities for native valves, CT superior for detection of abscess and complications, and a higher specificity of CT overall in prosthetic valves for reasons we've already reviewed. This is not to say that CT is a bulletproof test, however, as it should not entirely supplant TEE, because we know that CT can, on occasion, due to limitations of temporal resolution, miss smaller or highly mobile vegetations. Regardless, lots of promising data for use of CT in this particular arena. So in conclusion, some take-home points, hopefully I've emphasized in the last several minutes. Dynamic CT imaging is facilitated by modern CT scanner equipment and offers a myriad of insights into cardiac chamber and valvular function, but sometimes goes underutilized. It can be incorporated simultaneously with evaluation of coronary anatomy to permit a comprehensive cardiac examination, though increased radiation is a limitation of this approach. CT derives left ventricular and right ventricular ejection fraction approximates values obtained by cardiac MRI when performed properly. Multi-phase imaging permits visualization and accurate assessment of native valvular disease across a spectrum of pathologies. And lastly, there is a real and promising emerging role of CT in prosthetic valve dysfunction and native and prosthetic valve endocarditis as a complementary modality with particular strength in prosthetic and perivalvular complications. Thank you.
I'd like to thank all the panelists for sharing their expertise with us today, and would also like to thank our audience for joining this presentation. And with that, this concludes today's presentation, and will now pass along to Dr. Patel, Dr. Singh, Dr. Slivnick, and Dr. Henry for any questions from the audience.
Hi, first, congratulations to all the speakers. The talks, except mine, were all really outstanding. Mike, I have a question for you. You're really proficient with the software and kind of taking a look at the plaque and finding it. Do you routinely kind of really use MPR and look at the plaque in cross section like you showed here?
Yes, that's a great question. I think for me, the most important thing in reading a coronary CT is being systematic, and your eyes obviously get drawn to the most severe lesion or the biggest stenosis. So I think first of all, being systematic, and my system is typically to roll through the axial data set and note areas of concern that there's a potential stenosis. And after I've kind of evaluated the extent of the coronary tree, I like to take advantage of the using the MPR and doing a double oblique to really evaluate each stenosis from multiple planes, and then ultimately from an axial or from a short axis view of the valve to really get a sense of the severity of stenosis and kind of apply the appropriate degree of stenosis and related CAD-RADs.
Thanks, Mike. Looks like there's a question here to Dr. Singh. Maybe you can expand on this. Do you have any experience using cardiac CT to kind of prepare for transcatheter mitral valve interventions, possibly maybe a valve-in-valve or something like that?
Yeah, so I think, as I said, pre-structural heart intervention planning with CT, I think, is a topic of many hours of its own, and there's definitely a role for it. We do a lot of clinical CT for mitral valve disease, as I mentioned during my talk, both for preoperative but also for pre-catheter-based interventions. So when we're talking about mitral valve intervention specifically, there's a whole host of data that we get from the dynamic CT imaging, but also from kind of the individual phase images. So, some of the more important ones include just measurements related to the mitral valve, the annulus size, the subannular composition and components, the calcification burden and location, and there's a lot of data to support, the importance of those entities. The other thing that we spend time on is trying to predict or detect predictors of adverse outcomes, or dynamic LVOT obstruction being kind of the big one. So looking at the neo-LVOT dimensions. Some other predictors include kind of the geometry of the aortomitral area, and then things like the interatrial septum, which actually plays a really important role in the procedure itself, in that if the transeptal puncture is difficult, you sort of don't want to be finding that out at the time of the intervention. We can also rule out appendage. There are a lot of things that can be done, and I think serve as complementary data in anticipating and planning a successful intervention.
That's great. And it looks like there's also a question here for me, talking about when you might choose to do CT-FFR versus stress CT perfusion. And I think a little bit what you want to do is understand the pre-test probability. So if you've got a patient who you already know has severe calcifications or features of coronary disease that don't have that are not amenable to CT-FFR, such as patients with bypass surgery or stents, then you may very well preferentially choose to do a stress CT perfusion potentially followed by the coronary CTA anatomy secondarily, versus if you have someone who doesn't have known coronary disease, then in that case, I think CT-FFR first makes a lot of sense. And I think when you think about it from the perspective of the patient, patients already gotten their coronary CTA. That's all that they have to experience in the case of CT-FFR. The rest is us uploading and sending the images or using some software to do the FFR analysis, and it's no real added burden to the patients. And so whenever possible, at least in my practice, I try to really focus on avoiding doing extra things to the patient. So CT-FFR gets used quite a bit. Jeremy, I have a question for you. I know we've talked previously in other settings. I've heard you talk about using CT to look at the left atrial appendage to rule out thrombus prior to TE. Do you have much experience? Can you talk about some of your experience with that?
Yeah, so that's something that we commonly do here at University of Chicago. Is we're asked to perform CT pulmonary veins and CTs of the appendage in order to rule out thrombus, either prior to cardiac procedures such as ablation or prior to cardioversion. And also increasingly, we've been being asked by our neurology colleagues to perform CTs in order to rule out left-sided thrombi within the heart that could be a cardiac source of embolus to the brain. So we have a protocol here basically where we do a first pass perfusion with left-sided contrast opacification, which allows us to get a good look at the left atrial appendage. It also gives us a good look at the left ventricle to look for LV thrombi as well, which sometimes we can see in areas of infarct or aneurysm. And we do the same typically full phase with dose modulation that allows us to get that functional information as well. Following that, we also do a 45-second delay where we look to see, because in some patients who have low left atrial appendage function, you can have what looks like a filling defect on the first pass. But then when we give it time and wait, the contrast is ultimately able to reach the appendage. In those patients, it's usually typically due to just poor left atrial appendage function rather than a true thrombus. And that helps us increase our sensitivity for thrombi with less false positives.
That's great. Looks like there's a question here for Dr. Singh. Does functional CT perform well in evaluation of right-sided valves given limitations with contrasted and non-contrast blood mixing in the right atrium? I'm so glad I don't have to answer that question.
So I think this kind of gets to the point that, sometimes you have to individualize a scan. And so we know because of that mixing issue, I mean, in most of our run-of-the-mill coronary CT or arterial phases, sometimes it can be very difficult to discern the anatomy of things like the tricuspid leaflets. But this is where a triphasic injection approach can be really helpful, in talking to other imaging colleagues who do a lot of transcatheter-based interventions on the tricuspid. CT is routinely used to help screen patients in and out. And so generally the tips that I have heard from them are that the triphasic injection can make all the difference in these patients. So, I don't think that it is with adequate preparation. I think it actually can be a very helpful test. And I think it's just a matter of probably getting more familiar with those protocols at places that aren't doing it. Same thing goes for endocarditis and right-sided valves. You can definitely evaluate them, but usually want to employ the triphasic injection for that purpose as well to reduce some of those issues. There was another question I just want to answer really quickly about, how often, I don't know who the questioner is, but I don't want to skip over it. How often do you find halt following TAVR? And do you have a general guideline for how long post you would expect to have such a finding? And I think my understanding of the data is that this is, if you go looking for it, you will find, sometimes the prevalence that I mentioned, up to 10 to 13%. The challenge is that, sometimes that's in screening imaging. And, when you look in symptomatic populations, the number is going to be higher. So the typical time course is, people get a 30-day and then a 1-year echo, and that's frequently the instigator for the CT acquisition. But some patients who have normal gradients at 30 days can sometimes have halt at a year thereafter. So I think this is somewhat a reflection of your screening style. In our institution, we definitely use CT in patients where we see a sudden rise in the gradients, sometimes immediately after the case, but more frequently kind of at the 1-month mark. And sometimes it's just patient prosthesis mismatch. The leaflets look great, but we definitely employ it for that purpose quite often.
That's all the time we have for today. Thank you to Drs. Patel, Singh, Henry, and Slivnick for speaking at this GE Healthcare sponsored webinar. If you have any additional questions, please scan the QR code to post them. Thank you.